of the big things as you start, not just your residency, but even as a sub-I, is reading MRIs and CT scans, among other types of neuroimaging. So what I'm kind of going to give you is kind of a primer and introduction to doing just that. Actually, you know, when I was starting out as a sub-I, one of the most helpful things in that entire summer as a sub-I at Cornell was when one of the PGY3s at that time, one of my PGY3s, Alexander Ramos, sat me down and pretty much just explained to me how I should read, interpret, and present a CT or MRI. And I kind of carry that through all the way, and up till residency now, I still use some of the similar techniques. So initially, I'm just going to review some imaging modalities, the different types of scans we do, and I'll mainly focus on reading CT scans and MRIs just because of our time limitation. I think that's going to be the most high yield. And then we may look at a couple imaging studies and kind of put that together. And then I'll share some resources that you can use to help you along as you go through this process. And just before getting started, one thing I do want to say is the best thing that you can do besides, you know, any of this and all the background studying is to look at every CT scan, MRI your patient gets, even if it's not something of the brain or spine, even just looking at a CTPE study. You know, you learn everything and you learn best from when you do it yourself. When you review the imaging, you make your own interpretation, and then you move on and look at what the radiologist said. Just going straight to the radiology read is completely useless to your learning. So one thing I would encourage you is, as you kind of enter this next chapter in your career, is to make sure you're reviewing every image on your own first. So the different types of imaging we do deal with. Now this isn't everything listed here. You know, there's things like PET scans and MEGs that we won't get into, but CT scans are probably our most common. I like to call it to patients sometimes like an X-ray of the brain, because it's really that. It's just a quick, simple image. Here's an example of a CT scan, and then this is CT angiogram where contrast is used to better delineate the blood vessels. This is a CTA with perfusion, which is useful in cases where you're concerned about stroke or vasospasm. Here are some examples of MRIs. An MRA, which is a vessel imaging modality within MRIs, an MR spectroscopy, which actually can help identify tumors or other lesions. Down here, we see a digital subtraction angiography, or just an angiogram, as we call it. And this is a more invasive study. It requires a femoral or radial artery puncture, but it gives the best possible view of the vasculature in the brain, and it's extremely useful and necessary in most cases of vascular lesions. And these are transcranial Dopplers. We do use ultrasounds, especially in babies. So like I said, you know, there's a lot of tools in your armamentarium for imaging the brain and the spinal cord. There's things like spinal CT myelograms to better view the spine. We're going to kind of keep it simple and just talk about CTs and MRIs. So CT scans, like I said, it's like an X-ray of the brain. Essentially, it uses X-ray beams from multiple angles. It's usually a donut-shaped machine the patient's going into. And what it's measuring, what you're seeing, is how much the X-ray beam is weakened or attenuated by the material it's passing through. If it's air, it's going to be, it's not very weakened because it's low density. So that would be hypoattenuated, okay, or not weakened. If it's something solid like bone, dense material, it's going to be hyper attenuated or bright. So that's the terminology we use to describe it. And there's a range, and you can get more into the physics of it, but it ranges from -1,000 to over 1,000, water being the middle point. So most brain matter is a bit over 0, between 0 and 100, and it varies depending on the type of lesion it is. So like I said, the terminology we use is hyperdense, means it's bright, which means it's higher Hounsfield units, or hyper attenuated. So those are the terms that you use to describe CT scans. Hypodense are darker, lower density substances, and you can call those hypodense or hypoattenuated. Okay, so it's useful. Usually in neurosurgery, we use hyperdense, hypodense. The radiologists like to use attenuated. It's just more exact technical term, but essentially it's just describing how much the X-ray is going through this material. The pros and cons of CTs. CTs are rapid, they're cheap, it's useful for trauma, hemorrhage, fractures, it's quick and dirty. You can get the patient there quickly. In our ICU, we have a portable CT. Many ICUs have that, where you can just get it right there for a complex patient that's difficult to transport. It's useful for just quickly identifying, if someone has a change in mental status, you get a quick and dirty look. Do they have a large bleed, a large stroke, hydrocephalus, or increase in the size of the ventricles? And you can quickly rule out anything major life-threatening going on with a CT. The con of it is that it's less detail. It does involve radiation, so not ideal in pregnancy or in younger patients. And it has low sensitivity in the posterior fossa of the intracranial space. So here's some examples of hyperdense structures. So here you can see it's pointing to the bone, right? So bone is very calcified material. It's very dense, so it's going to be extremely bright. And CT scans are excellent for looking for fractures both in the brain and spine. You can adjust the windowing, when you are looking at these, to get a even better view of the bony anatomy. And you often have to do that. You often have to play with the windowing to kind of look at lesions better. This is just pointing out some calcifications, which you can commonly see. Sometimes you'll see it in the basal ganglia, sometimes in the ependymal space, or in the choroid plexus, which is what you're seeing here. This is the tip of a ventricular catheter. As many of you may know, one of the main and quickest and most common interventions that you'll do as a neurosurgeon, especially as a junior neurosurgeon, is a ventricular drain placement for someone with hydrocephalus or buildup of fluid in the brain. So this is a type of image you'll be seeing for a long time. And then here was pointing out a basal ganglia hemorrhage, which also, because it's blood is hyperdense on CT. So that's what you're seeing there. Things that are hypodense, air. This is a case of pneumocephalus, so someone that may have had a endoscopic skull-base surgery and developed a CSF leak, can track air into their intracranial space, and that'll be very dark. Air is the lowest Hounsfield unit, the most hypoattenuated thing. As you can see, this is all air right around the patient, so that's very easy to identify. Here you can see this is a little less attenuated than the air. So it's brain tissue, and it's likely showing an area of edema, cytotoxic edema potentially, maybe even stroke. It's a posterior MCA territory here that we're seeing. So here it's pointing to the CSF, which is closer to water. So again, more hypoattenuated. And then ischemic territory. So when you have decreased blood flow to the brain, you have increasing edema, infarcting of that tissue, and that also shows as hypoattenuation. So that's really important for stroke visualization. If we had more time and we weren't in a virtual setting, I would kind of go through and quiz you on these, but either all the different, not all, but like a wide variety of pathologies you may see on CT. I'm going to quickly go through it. And when I get a CT scan or an MRI, I always have a very systematic way of looking through it. I start from the top of the brain all the way down, and I'm quickly just looking through for any major pathologies. And then I'll kind of go through, and the things you're looking at is, how do the lobes of the brain appear? Are they normal? Often asymmetry is going to be your best guide to identifying if there's any issues. You look at the sulci. Are they effaced, which can be a sign of swelling and elevated ICPs? Is the brain shifted over? Are there any intraventricular or subarachnoid blood? So that's what you're looking for. Here we see an area of hypoattenuation, so that's likely some type of edema. Here in image 2, you're seeing clearly asymmetric hyperdense sign here, and that's called a hyperdense MCA sign, which identifies that there's a thrombus, a clot here in the proximal MCA, which you will often see in MCA strokes. Here you see an ovoid hyperdense structure causing effacement of the surrounding sulci. mass effect around it, which is a term we use to describe just pressure on the surrounding brain, and that's clearly an intracranial hematoma. Here we see intraventricular blood. See how the hyperdense blood is all in the CSF space, and that's a sign of intraventricular hemorrhage. One of the problems with intraventricular hemorrhage is it can block up the CSF pathways in the brain and cause hydrocephalus, which is why they likely have a ventricular drain, which is what you see here. And you can also see, notice the difference in the sulci here. You always want to look at that, especially when you look down in the temporal lobe and down near the brainstem. You want to be looking at the sulci, what kind of shift is happening, and you can often see mass effect and shift and compression of the brainstem as you scroll down. And that's an important thing to recognize. Clearly, this patient has severe hydrocephalus with elevated ICPs and diffuse cerebral edema from that. Here, kind of more classic image that I'm sure has come up a lot in medical schools, a subdural hematoma. It's likely chronic because it's hypodense. As blood kind of ages, it liquefies. And so it becomes dark, more hypodense. Here we see an interhemispheric acute subdural. This is a large epidural hematoma. It's bright, it's lens shaped, it's causing massive shift and mass effect. Bilateral subdurals, mixed density. You see how it's brighter here. So the more dense blood, probably the more acute blood, is kind of tracking down here because the patient's lying down on their back. So you have to account for those things too. And then the more chronic blood is up here. So probably someone that was on anticoagulation, had a fall, and it's been intermittently worsening bleeding. Here you see hyperdense material filling the subarachnoid space, right? It's in the sulci, it's filling all these little crevices, and that's a sign of subarachnoid hemorrhage. It's cortical, so it could be trauma. You really have to know the history, but if they had a sudden onset headache, it's likely that they had an aneurysmal subarachnoid hemorrhage, and you'd want to continue on and get vestal imaging. That's another thing with all types of imaging. You always want to look for what type of imaging do you get next. And then, one other thing to keep in mind, it's pretty cortical, the subarachnoid blood, so you'd want to get a better history because, you never want to miss a mycotic aneurysm or an aneurysm caused by a bacterial infection. So that's something to keep in mind. This is some vasogenic edema. This is encephalomalacia, so probably this area of brain had been stroked out or if they had a surgical resection. And then this is a clear aneurysmal. It's a stellate or star-like pattern, right? So this cut is a bit lower down than all the others. It's near the skull base, which is where you're going to see most of the blood and subarachnoid hemorrhage. You see here the cerebral peduncles. This is the midbrain. You see the medial portion of the temporal lobe. These are areas that you want to be looking for to see if there's mass effect or shift compressing the brainstem or causing transtentorial herniation. And then, as you can see, this bright star-like pattern, that's a clear and obvious sign of a subarachnoid hemorrhage, probably from an aneurysm in the skull base, usually an anterior communicating artery, or even over here, it could be a basilar tip aneurysm that bled. So again, like I said, a lot of these, that's kind of the pathology. What you see is what you get. There's nothing further to do. But in intraparenchymal hemorrhages, keep in mind, do they have a cancer history? Could this be a tumor? This doesn't look like a tumor. This just looks like a primary hypertensive hemorrhage. But it's important to keep in mind things like, do we need to get an MRI down the road and look to see if there's tumor there? Obviously, in an aneurysmal subarach, they'll need a CT angiogram and also a DSA or a regular invasive angiogram to identify the aneurysm. So moving on to MRIs. MRIs are large magnets that basically align the protons and hydrogen or water molecules in the body. Radio waves are shot through the patient, and the returning signal, the shift in the movement of the protons, is converted into an image. And because of the difference in the amount of protons in various tissues in the brain, very subtle acute differences, you actually can get a very detailed view of the brain. And the MRI has become absolutely essential in our work to identify lesions, especially when it comes to neuro-oncology. So the terminology we use for MRIs is not dense because it's not measuring density, it's measuring the intensity of a signal as it comes back. So we use hyper intense for bright on MRI and hypo intense for dark. And keep in mind, MRIs are often, as with CTs, you can get with or without contrast or both. So hyper and hypointense just refer to non-contrast enhanced imaging. And when you are using contrast, then you talk about is it enhancing or not. And we'll get into this a little more. And there's multiple sequences which we'll review. Quickly, the pros, it's more detailed, it's safer in pregnancy or peds. You can get imaging of the vessels. You can get an MR angiography without even giving contrast. So in someone with renal issues, that's important. It is more time consuming. It can take up to an hour, sometimes less for just fast sequences. It's expensive. There's more contraindications. You have to think about metal implants. And the patient must hold still, and it can be difficult if you're claustrophobic. And one of the most frustrating things as a junior resident, and you'll find this out quickly, is getting people to MRIs. Sometimes it can be a breeze, and sometimes it can be a big pain if they have any of these issues. So the first sequence that you're usually going to be looking at is a T1 sequence. On T1, and we're not going to get into the physics of all the different sequence types, but basically they're just different ways of altering the water molecules and the radio waves to get different types of images. So on T1 is great to look at just normal anatomy. CSF is dark, the white matter is white, and the gray matter or the cortical areas is darker, it's grayer. So if you're ever, the most important thing when you get an image is to talk about what image it is, what sequence it is. So for T1, just think it's the first one, it's the normal one, it's the normal anatomy. So if the white matter looks white and the cortex looks gray, then it's a T1 sequence. And, it might seem trivial, but actually you'd be surprised how many people have trouble identifying a T1 or a T2 sequence. So one important use for T1 is hyperintensity in T1 sequences are seen in lipid-containing tissues, right? And you can see that here. You see the scalp is bright. Here around the bone, the subcutaneous tissues, the fascia, okay? Those are the things that are bright. So melanin, calcifications, protein-filled fluids, and subacute blood products all would be bright on T1. T2 sequences is kind of a reverse image. So the CSF is bright or hyper intense. White matter is dark. So if you see dark matter, it's like the negative, okay? Just think of it as flipped from the T1. T2 is very helpful for showing pathology, whereas T1 is good for normal anatomy. T2, sorry, switching screens here. T2 is good for identifying pathology, abnormal brain tissue, tumors, that sort of thing. What you can also get is a T2 flare, which basically just subtracts out the CSFs. Here you can see the CSF is bright, so all the subarachnoid spaces, the ventricular space, it's all bright. If you take that out, you get better contrast, and you can identify things like flare edema, which you see here, cytotoxic edema, basically like things like edema, pus, or cysts would light up better. So if you can't identify some things like a cyst or some other material, you take out the CSF and you get a better image with a T2 flare. And then the diffusion weighted image, absolutely important for us to see. Basically, as dying neurons swell, their sodium potassium pumps stop working and water accumulates within the cell. So if the diffusion of water, so if water is accumulating there, its diffusion is restricted, and restricted diffusion brightens on this type of sequence. So if you just think of the name, you can kind of identify what you're looking for here. So things that you're going to see diffusion restriction or restricted diffusion of water molecules bright on DWI are ischemia, abscess, lymphoma. Often lymphomas have a classic, this is probably a stroke, but lymphomas will have a classic light bulb sign, almost bright. The entire lesion is diffusion restricting, and that's a very classic sign of lymphoma. Whereas something like GBM, and I'm sorry I don't have any good pictures of that here, but something like GBM might be more patchy diffusion instead of the whole tumor being diffusion restricting. And then susceptibility weighted images are good for showing blood. And I'm running a little on time, so I'll just speed it up a little bit, but essentially blood will be dark. It shows flow void. So blood vessels and blood or hemosiderin will be bright, and there's different names for it, so just look out for that. So As a resident, when you're, one of the things that you're going to see a lot of are pre and post-op MRIs for tumor. Okay, and you're going to have to be looking at every single one of those scans in every patient that you take care of and compare what their brain looks like before and after the surgery, before and after the tumor resection. And you're going to have to be looking at the DWIs to identify stroke. You have to look at the T2 and the T2 flare to identify if there's cytotoxic edema, which could happen from venous injury. And you absolutely have to be looking at the pre and post contrast MRI. We'll talk about contrast in a bit. Contrast shows breakdowns in the blood-brain barrier and are important for identifying tumors. And you're going to be having to look at those. I'm not going to belabor this, but just something to reference is there's different mnemonics that you can use to identify blood and the age of blood on MRI sequences. And this is how you can identify if someone has an acute, subacute, or chronic hemorrhage. You can find a lot of this online, so I'll just skip past here. Some imaging findings, and the same way. So when you're talking about an image, you want to identify the sequence, okay? So here we see, this is, I think actually, so you can see how sometimes it's tough to tell, but you just have to look at the white matter tracks. So here you see white matter, the axons are dark, and we know that's T2. The CSF is also dark, so this must be a T2 flare, okay? So you always want to take that first step just to identify what you're looking at. And here we see signs of MS. So you see hyperintensities in the white matter spaces. That's a classic sign of MS. Here is so that was a sagittal cut. This is an axial cut. You always want to identify cut and sequence. Axial cut, again, dark white matter, T2, and it's a flare because the CSF is also dark, unlike a regular T2 where it's bright, which you see here. So here we see temporal lobe edema, probably from some encephalitis, cerebellar atrophy. You see the atrophied cerebellum here. This is a T1 post-contrast scan. I don't even have to think about that much. I mean, it's clear based on the white matter being white and the cortex being dark that it's a T1 image. And these are clearly dural-based round lesions growing into the intracranial space. And that's a classic sign of a meningioma. And the only time you'll see a meningioma this bright and prominent, diffusely enhancing, is in a T1 post-contrast scan. So you always want to identify, are you looking at a T1 pre-contrast or a T1 post-contrast? There's other little tricks. You can look at the sinuses. If the sinuses are bright, you can look at the choroid plexus. Sometimes you'll see brightness in the choroid plexus. And just like I said, as you look at more and more and more of these images, you'll just become more adept at identifying it. This is a DWI. I'm just going to skip around a bit, which you can tell kind of has a usually fuzzy image, and then this hyper intensity. So this brightness on DWI is in a round, discrete, well circumscribed area is a sign of an abscess. So when do you use contrast? We talked about it a little bit in the last couple slides. For CTs, you don't really use it. It's almost always going to be non-contrast, but times that you might need it is if someone can't get an MRI and you have concern for a tumor or an abscess, you can identify that with a CT contrast. It'll give you better definition because contrast in both cases identifies breakdowns in the blood-brain barrier. So things like tumor, like abscess, traumas will show that very well. MRIs with contrast, like I said, infection, abscesses, tumor, demyelination. Angiograms use contrast by virtue of what they are. You know, you're not going to, it's a you're doing fluoroscopy, and you're not going to get an image unless you are shooting contrast into those vessels. So that's an essential thing there. And then just a mnemonic for identifying contrast enhancing lesions. If you have a ring enhancing ring shaped contrast enhancing lesion, the things that you want to absolutely be thinking about are tumor and abscess. You know, there are others like infarction, demyelination, radiation, necrosis, but tumor and abscess are going to be highest on your list. And then you have to kind of compare to other sequences. Look, you're never going to get a differential diagnosis from one sequence. It's always best when you're looking at multiple sequences. So very quickly, as I wrap up here, like I said, one of the best things that you can do as a sub-I or as a resident is communicate imaging results well. And I can't even begin to emphasize how much brownie points that'll win you if you become adept at describing imaging findings well. You will kind of, you really will look good in the eyes of everyone around you. And more importantly, you'll be a better clinician for it, okay? So the best thing to do is to be direct, efficient, and consistent. Do it the same way every time. And I've been doing it this way since I was a sub-intern and I was taught this kind of method. So the first thing you do is you name the sequence. So what type of image is it and what cut? Is it a sagittal, axial, coronal? Is it an MRI or is it a CT? Is it contrast or non-contrast? Okay, so that's what you have to describe here. Then you can move on to identify the lesion. Almost always you're gonna have a lesion. And when you're identifying the lesion, the first thing to do is identify its location and its characteristics. So right frontal, is it large, is it small? Estimate the size. After a certain point, you're gonna be able to just look at something and be like, oh, that looks about like 2 to 3 centimeters, okay? Is it hyperdense or hypodense if you're talking about a CT scan? Or is it hyperintense, iso-intense? That's another term. If it looks similar to brain, but slightly abnormal, you can say iso-intense or isodense. Is it enhancing, non-enhancing? And for MRIs, you want to talk about how it appears on various sequences. So it's a T1 post-contrast enhancing lesion that shows signs of diffusion restriction. That's already leading you to think, okay, maybe this could be a GBM. Then you can move on to identify what surrounding effects and changes to the normal brain architecture you're seeing. Is there vasogenic or cytotoxic edema? Is there sulcal effacement, midline shift? Is there signs of herniation, signs of hemorrhage? You could have hemorrhagic tumors. You could have a tumor that's causing compression of the third ventricle or of the cerebral aqueduct, causing hydrocephalus. So you want to identify that. If you see another pathology on the imaging that is likely related, you want to identify that. And then finally, you put that all together and you give what you think the most likely diagnosis is and what you think the differential diagnosis is. And I guarantee you, if you do it this way every time, systematically, hitting on all these key points, it's really going to go a long way. So I'm going to just do a couple cases. One's a CT and one's an MRI. So I'm going to just scroll through here slowly so you all can take a look at it. Okay, so as I said, I start from the top, I work my way down. I'm looking at the brain architecture. You can already see a little bit of shift towards the right. And remember, when you're looking at imaging, it's like you're looking from the bottom of someone's feet up into their head. So this is the right side of the patient. This is the left side of the patient. You see a left frontal intraparenchymal hemorrhage. I'm kind of skipping ahead, but a large hyperdense structure, right frontal, likely representing an intraparenchymal hematoma, causing midline shift with intraventricular extension of blood, causing hydrocephalus and subarachnoid blood as well. You see blood in the subarachnoid spaces here as well. This patient was actually a patient with COVID-19 who was super therapeutic and hypertensive on anticoagulation and just developed a primary hypertensive hemorrhage that expanded, and unfortunately they died from that. And then here's an example of an MRI. Okay, so I'm sorry, it's not super bright here. It's a little tough to see, and this is my last slide now, so I'll be wrapping up any second. But here you see white matter is white, the cortex is darker, so it's T1. You see brightness in the vessels, in the sinuses, brightness in sinuses here, and in the choroid plexus. This is clearly a T1 post-contrast MRI. So when you're describing this, you'd say, okay, this is an axial cut T1 post-contrast MRI. I see a large 3 to 4 centimeter enhancing round lesion in the left cerebellum, causing surrounding mass effect. And we don't have other sequences here, so we can't really talk about edema as much, but that's another thing you would want to comment on. And then quickly here, always the Greenberg Neurosurgery book is useful for anatomy and neuroradiology. This link I love. It it's the chapter on neuroradiology in the Neurosurgical Atlas, and it breaks down the different MRI sequences really, really nicely. This has been very useful for me early on when I was still kind of trying to identify the different MRI sequences. Radiopedia, always a great one. I follow them on like Twitter or Facebook, and they sometimes have fun links. And then I love this website for I can't pull it up on my Mac, but on the work computers we can pull it up because it uses Flash. But it basically has really good quizzes where you can test yourself on different anatomies. So basically it'll have an MRI and it'll just highlight a specific area, and you have to guess what it is, and it just runs through multiple anatomical areas. This is not only useful for looking at imaging, but also just testing your neuroanatomy. I train all my interns with this. I basically, at the end of sign out, I sit them down and we just go through a bunch of sequences until they get it perfect, until they can identify every vein, artery, and brain structure. So hopefully you guys will get the link to the slides and can use this. And I just want to thank Dr. Jenna Ford and Dr. John Sosaurus for a lot of the resources I used here in these slides.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.